I'd like to introduce John Beca, who's Director of Critical Care at Starship Children's Hospital, has a long-standing interest in neurocritical care, brain injury in children, post-cardiac surgery, traumatic brain injury and hypoischemic injury. Thanks, John.
Thank you, and this slide might reflect how some of you feel this morning. So thank you very much to the organising committee for the opportunity to speak today, and thank you, Johnny, not really, for the title. And in fact, the title itself tells a story, because about 10 years ago, if I was being asked to talk about cooling after cardiac arrest, it would usually be some sort of title like, is it cool to be cold, or something along those lines. And now if I'm given a title, it's much more like, is it the end of the road, have we gone cold? So that, I guess, tells where we've come in the last 20 years. And so what I want to do is just go through how we've got here and what we've learned along the way. And this is where it started. This is this is the Animal Research Lab at Auckland University, and where Professor Alistair Gunn was one of the leading people internationally. There were 2 or 3 sort of labs around the world that did all this original work that defined the amazing sort of neuroprotective properties of hypothermia. In particular, he defined, this was through the 1990s, he defined that the time window that's required for hypothermia to have an effect, and showed that it was pretty short, that by about 4 or 5 hours the effect was sort of 50% lost, and beyond that it was almost entirely lost. He defined the optimal temperature and the optimal duration. And I was reflecting on my way over here that in fact in 1999, so nearly 20 years ago, Alistair presented this work at the at this same meeting, at the ANZAC's meeting in Christchurch. And many of us in the room were so convinced by this data, we just went out and started calling our patients. Like, we didn't need trials. The neonatal stuff hadn't even come out at that stage. It was beginning to come out, but we all went out and were totally convinced that this was the treatment. And I think Frank Shan still is. He was totally convinced. So I guess one of the conundrums in the hypothermia story that we need to explain, and I think we have some theories around this, is that unarguably in neonatal hypoxic ischemic injury, so after birth asphyxia, cooling is highly effective. Depending on which meta-analysis you look at, there are sort of 8 to 10 trials, there are 1,800 babies that have been in these trials, and the good thing about the neonatal trials is they're all very consistent in terms of how they're done, both in terms of the duration of the hypothermia, the target temperature, and the outcome assessment. And you can see, this is just one of the meta-analysis, this very consistent finding between studies that death or disability at 12 to 18 months is reduced with a risk ratio of around 0.73 and an absolute effect size risk reduction of 16% and a number needed to treat of 6. And if death and disability alone is not enough to convince you, then if you look at other outcomes as well, whether it's cerebral palsy, blindness, deafness, and in fact even MRI injury has been shown to be reduced by cooling. So I don't think there's any doubt that it's a very effective treatment in this group. So then when we come on to children and adults, the evidence is much less convincing. In fact, there is no evidence that it's effective in the same way as it is in neonates. So let's talk about children. And I'm not going to sort of dissect all the papers in great detail. You'll be relieved to know, apart from the one major study, or the only big randomised controlled trial in children. But prior to that, there were 2 big cohort studies performed in 2010, 2009 that showed no difference in mortality if cooling was used as opposed to when it wasn't used. And we in fact did this was a pilot study done with Jamie Hutchinson in Toronto and GOS. It was a prelude to the THATCA trial, again looking predominantly at safety but also seeing no effect. And you'll all know the THATCA trials. I guess this is the only randomised controlled trial data that there is in children. It's a pair of trials looking at in-hospital cardiac arrest and out-of-hospital cardiac arrest, and this is the out-of-hospital group. And so there's a few, I guess, points I just make about the study as we go through, and I think there have been some really interesting follow-up studies as well that are helpful, particularly about cardiac arrest in children, less so about hypothermia. But this study for the out-of-hospital cardiac arrest group looked at children up to the age of 18 years. You had to have had a cardiac arrest for longer than 2 minutes, or chest compressions for longer than 2 minutes, a motor score of less than 5, and then be randomised within 6 hours. And both groups had targeted temperature management for 120 hours, the hypothermia group for 33 degrees and the control group for 36.8 to 36.8. And the primary outcome was what's called the Vineland score, adaptive behaviour score. It's like most many developmental outcome scores. It has an average of 100 and a standard deviation of 15. So the outcome measure they used for a good outcome was a score above 70, which essentially means you're better than 2 standard deviations below the mean. That was the primary outcome. One of the sort of alarming things, I guess, reflects our knowledge of these children is that quite a high proportion of them were not developmentally normal prior to the event. And so the secondary outcomes looked at survival, but in particular, the one that I sort of thought was most fascinating was the change from baseline score. So the Vineland score is done on the basis of a questionnaire. You can do it by interviewing parents. So the majority of children in the study had a score done to look at their pre-arrest developmental outcome or developmental state. The sample size, when you look back, was hopelessly sort of optimistic. Primary outcome rate, it's not too, they expected the sort of bad outcome rate to be somewhere between 15 and 35%, which wasn't too bad. It turned out to be 15 to 20%, but the effect size was, the sample size was based on an effect size of 20%. And you look at it now and think, like, how could you imagine that would be the case? I mean, it was based on the neonatal data, which showed a 16% effect size, so perhaps not quite as sort of optimistic, but you can understand how they developed that. If you look at the actual children in the trial, it again reflects what we would all be used to when you're dealing with out-of-hospital cardiac arrest. Relatively less than a half were bystander witnessed, and when it was bystander witnessed arrest, only 2/3 had CPR performed by that bystander. Half had a pre-existing condition, the majority were respiratory, and these were like serious cardiac arrest. So the median duration was 25 minutes. 2/3 of them were still getting CPR on arrival in the emergency department, and the median number of adrenaline doses was 3. And here's the outcome. And again, you'll all know this data. I'm sure there was no statistically significant difference between groups. There was an 8%, if you are a believer, I guess, the hypothermia group had an 8% better outcome in terms of the primary outcome. But if you look at the group that scored within 1 standard deviation of their baseline state, the outcomes are identical. So in this study, there was no difference in the primary or secondary outcome. It was an underpowered study. If the difference really is 8%, you would need to do a study with 900 patients. So, way more than was done in the study. Probably they were called too late. If you look at the animal data, median time to start cooling was 6 hours, and they reached their goal by just under 3 hours. And I'll come back to the heterogeneity of the injury. This was followed by the in-hospital cardiac arrest component of the study, which was published a couple of years later. Same inclusion-exclusion criteria. It was set out to be a much bigger study, as is well sort of known. The outcome for cardiac arrest for in-hospital patients is much better, so it was expected there would be a 35 to 55% favourable outcome, and it was powered to detect a 15% difference. And the study was stopped for futility after just over 300 patients. And again, it showed even more dramatically no difference in outcome. So identical outcomes really between groups. And so there was no difference in any outcome measure or on the rates of any adverse events. And that's the same data as I showed you before. Again, you'll see the proportion that score within 1 standard deviation of their baseline state is exactly the same. There's a real problem, I think, with the in-hospital study, and it was always going to be a weakness. And again, it'll reflect what you're all well aware of in your own hospital. Who has cardiac arrest in hospital? Predominantly, it's children with a cardiac condition. So 2/3 of them had a cardiac condition, a half were placed on ECMO. And in fact, I think the major problem in terms of sort of further underpowering the study was that 2/3 of the children died for non-neurological reasons. So you don't know what their neurological outcome would have been. They either died for cardiac reasons or multi-organ failure or sepsis. And only 1/3 of them actually had treatment stopped for neurological reasons. There have been a number of follow-up studies, and this is looking at the drowning subgroup. So it's actually quite a big cohort of children who drowned. And drowning, as you'll all be aware of, typically is about 1/3 of children who have an out-of-hospital cardiac arrest. And interestingly, it's actually a group that has a better outcome than other respiratory causes. And that's not necessarily a reflection of the fact that drowning has a good outcome. It's a reflection that all the other respiratory causes have a really, truly dreadful outcome. But anyway, with 74 children, and the trends in terms of hypothermia were exactly the same. Somewhat a non-statistically significant, slightly better outcome in the hypothermia group. But again, if you look at those that score within one standard deviation of their baseline, it's almost exactly the same. And I think there's some quite useful outcome information in this, in that if you look at the whole cohort, there were no children that had a good outcome if their arrest lasted for longer than 30 minutes or they had more than 4 doses of adrenaline. So I think that's sort of useful in terms of prognostication about these children. There have been several papers looking at prognosis for out-of-hospital cardiac arrest. In fact, they've published both out-of-hospital and in-hospital cardiac arrest, but this is for the out-of-hospital group. And again, there are no particular surprises. Good outcome is associated with a cardiac cause, with an arrhythmia, with a shorter arrest, and children that are in the sort of 1 to 5 year age bracket. Less than 1 or 6 and above, they had a worse outcome. And factors associated with a bad outcome were more than 30 minutes of chest compression, an arrest occurring in the weekend, and a non-drowning respiratory cause. And looking at their sort of neurobehavioural and cognitive outcomes, so the Vineland score is a global score. It's got 4 domains, and there was a further paper came out a week or 2 ago looking at their more detailed cognitive outcomes. And if you look at those children that had a broadly normal baseline function prior to their arrest and how do they do subsequently, for the in-hospital group, it's not too dreadful. Like 60% of them end up being broadly normal after the cardiac arrest, and only 16% scored the lowest possible score. And if you look at one of the bad groups, those over the age of 6, the majority of them actually have functional communication. But if you look at the out-of-hospital group, only a third of them are broadly normal, 43% scored the lowest possible score, and for the kids over 6, 50% of them lack any form of functional communication. So I think what we can say at this stage is that the only randomised controlled trial in children does not support moderate hypothermia, and that paediatric HIE after cardiac arrest is typically very severe, and that cooling is achieved relatively late, from what we know of the physiology of neuroprotective effects. So that's children. What I want to do is come on to adults now, because I think this trial is just fantastic. It's it's easily, I think, the best trial that's been conducted in post-cardiac arrest neuroprotection, and includes like nearly 1,000 patients. So it's known as the TTM trial, more than twice the size of the original trials that were done in the early 2000s combined. It had a really good protocol for withdrawal of life-sustaining therapies, and in this trial, about half of the patients had a good outcome. And there was no difference between cooling to 33 degrees and cooling to 36 degrees. And so, if you look at the TTM study and compare it to the 2 trials that came out in 2002, you can see in blue is the good outcome rate in the hypothermia patients. And you can see it's pretty concordant between the trials. What's changed is the control group. So you can see the non-hypothermia group, the outcome is much better in the TTM trial compared to the previous 2. But I know the authors, there was a meeting about a month ago in Sydney from the, believe it or not, International Hypothermia Society. And the authors of that trial spoke at that meeting and were very clear about this trial has been sort of quite misrepresented in terms of what people have thought it has shown. And what they were very clear about is that it doesn't show that hypothermia does not work, and it also doesn't show what I guess many people have interpreted, that fever control is what matters. What it shows is that if you're going to use targeted temperature management and control temperature for 36 hours or so, then there are very similar outcomes whether you use 36 or 33. That is all it shows. And that is their justification for going on and doing a second trial, which I'll come on to. So, why is there no effect when you look at it compared to the neonatal trials? Is it something to do with the duration? And this is an adult trial published last year, which looked at 48 hours compared to 24 hours, and again showed no difference. If you look at what the trend is here, there's a potentially 5% difference, or a sort of point estimate. and that the 48-hour group had a 5% better outcome rate than the 24-hour group. If you were going to try and look for a 5% difference in adults, you'd need a trial of 3,000 patients. Is it speed? We know that from the animal studies, you've got 4 to 6 hours. Again, in adults, there are now 6 trials, 2,500 patients almost, where cooling was started pre-hospital. And in all of those trials, consistently, there was no difference in outcome. So it's probably not that. But certainly being able to cool by 6 hours is really important. This is, again, a paper that came out last year looking at neonates where they cooled them after 6 hours. So the ones that wouldn't fit into the normal guidelines, and found an absolute difference of, again, a non-statistically significant difference. They used Bayesian analysis to try and work out what the probability of that effect still being present was, but an absolute difference that's about probably 3.5%. Thank you, Liz. So that compares to a 16% effect seen in the original trial. So time probably does make quite a big difference. And again, this is just looking at in-hospital versus out-of-hospital arrest. This is an adult study looking at in-hospital arrest and cooling. It's using very large numbers from the Get With The Guidelines registry and selecting a group that had hypothermia and then matching them to a whole lot of patients that didn't have hypothermia, and in fact showed a slightly worse outcome with hypothermia in this group. And so, is it severity? I think this is, and I guess having spent some time talking to Alistair Gunn about it, as he's as puzzled as everyone about why it looks so convincing in animals and it looks so convincing in small babies. Is it severity? And this is actually looking at the neonatal data, where a number of those studies actually categorised the children about whether they had moderate injury or severe injury. And you can see here that the treatment effect in those with severe injury is much less than it is if they had moderate injury. And this is a group of, the babies in these studies, most of them, about a third of them had a cardiac arrest. So these babies didn't even have a cardiac arrest, a majority of them. And so using that, you'd say that, there's certainly a very powerful effect in the moderate hypothermia, in the moderate HIE, but much less in severe HIE. And we know that in children in particular, the injury is very severe. And that's the problem we face. So, do we just reject hypothermia in children? I think you'd have to say that there is certainly no evidence for using moderate hypothermia. But one of the problems with doing randomised controlled trials is that you assume, or one of the assumptions is that all the patients in the trial have roughly the same prognosis, and we know that's not the case. And particularly it's not the case in post-cardiac arrest. There's a group of patients that we know are going to have a devastating injury. There are some that are going to do well. So the group where it might make a difference may well be quite small, but more importantly, we have no way of knowing how to identify them. And finally, just to finish up, talk about fever, because is it all about fever? What we do know about fever is that it's really bad for the injured brain. We know that from animal studies, and we know that for every degree increase in temperature above 37 in adults and children and neonates, outcome is dramatically worse. What we don't know is whether controlling fever changes outcome. We don't know whether it's an association or a cause. But we also know that we're really bad at controlling temperature. So whether it's in routine clinical practice, like as the first study shows, where this was after guidelines came out talking about controlling temperature, that almost a half of children in North American hospitals had a temperature above 38 degrees. And even in clinical trials, in the Cool Kids trial and in our own HITBIC trial, where we hoped that everybody was really zealous about controlling temperature in the control group, we didn't do that very well. So the TTM2 trial, which is the follow-on adult trial, which is being planned and I think is funded now, is going to compare, and it's going to be even bigger again, so I don't know what the sample size is, but it's considerably more than 1,000 patients. Is actually going to compare 33 degrees with early treatment of fever, and that will answer whether it is avoiding fever that is what really matters. So, I guess my summary, have we gone cool on cooling? Well, I think we can say without a doubt that there's no evidence in children or adults that moderate hypothermia is any better than mild hypothermia. And we can also say that cooling for 48 to 72 hours is no better than 24 to 36 hours, based on the trials in kids and adults. So again, our practice would be to follow the adult guideline, the so-called 36 for 36, so controlling temperature 36 for 24 or so hours. We can also say that there's strong evidence that fever is associated with a worse outcome in brain injury, but the evidence for actually controlling temperature and avoiding fever is very weak. But the TTM2 trial should answer that. We can say that there's strong evidence that it improves outcome in babies with birth asphyxia, and I think the difference there is most likely to be a combination of the less severe injury and the fact that they're cooled slightly faster than we're able to manage. And if we're ever going to have any hope of finding out whether hypothermia does make a difference, we're going to need tools to assess severity and then be able to stratify trials according to severity, and probably to use alternative trial designs, because we're never going to be able to do this with conventional randomised controlled trials. Thank you.
Thanks, John. It's brilliant. Any questions for John?
Phil.
Oh, sorry, Phil. No, Phil.
Don't fight.
Later. I was just interested to ask you then, in TTM2 that's planned, with the data that exists showing, I think what you're saying is no effective difference between 36 and 33. Why have they chosen to make the other arm 33?
Yeah, look, that's a really good question, and I've thought about that myself. I guess if you're setting out to go, I mean, people argue about what is normal body temperature, what is 36, is it mild hypothermia, is it just a good way to avoid fever? I guess if you're going to try and say, is it about fever prevention or is it about hypothermia, then I can understand why you might go with 33. It's not that there's anything worse about 33, they're roughly the same, but there's still quite a lot of debate about what 36 represents. There's some physiological evidence that even at 36 that you get release of various mediators that might actually help to protect the brain. So it's sort of unclear what that represents. A lot of people have gone, it's all just fever avoidance, and that might be the case, but I guess that's what the study is going to be set up to show. Phil.
John, are neonates just a different species? Is there something different about neonates, the physiological pool or other sort of things? Because we've got a few studies from the Burns stuff around burning small little embryos and then putting them back in and they come out fine. Is there something different about neonates? Should we be looking at what is different about neonates' physiology to try and put that into what happens with kids rather than the cooling in and of itself?
Yeah, maybe. I mean, interestingly, if you look at the animal data, in fact, the effects are there in, it's across ages in animals, pigs, sheep, whatever you look at. The effect isn't just in, Alistair did all the work in fetal lambs because mothers provide cheap, intensive care for their babies in utero. But it's been shown in fetuses, it's been shown in newborns, it's been shown in sort of child pigs and lambs and things like that, and in adults. So yes, it's possible. I think the most likely thing still is actually the severity and the timing.
We've probably got time for one more question if there's anything from the floor. Oh, do you need the mic? You've got a very good speaking voice.
Because in adults, I've actually followed the literature very closely. One of the fascinating things is applying it in practice. We have in Brisbane 2 hospitals doing 2 different things, just because there's a river in between, I guess. So we are doing 36 because we thought as a group that 36 is the way to go. And another hospital is sticking to 33 because they're saying that there's no difference in outcome. I'm just interested in knowing what is being practiced in your hospital and how pediatric sort of word is in Australia is interpreting this and applying practice.
I think there are still differences. I can tell you in Auckland, both in our unit and in both the adult units, they follow the 36 for 36 protocol. But that doesn't mean there's not variations in practice around the rest of Australia and New Zealand. I think because of those variations, and because certainly after the TTM trial came out, and in fact they've published that data now that shows that there was a massive uptake of that protocol around Australia and New Zealand. Paul Young's just recently published from the ANZAC's trials group looking at temperature control since people have taken that up. And there's a very minor deterioration in outcome. This is, again, it's all sort of registry data. But over the last, since there's been a change to 36 from 33, outcomes have got slightly worse in Australia and New Zealand, and temperature control has got slightly worse. So I think that shows the challenges of trying to sort of control temperature around 36. I mean, it's all sort of, I guess, adds to the reason as to why we need to do another study around temperature control. But there is the circumstantial evidence that temperature control has got worse when we've shifted to 36 from 33. So you could argue it either way, and I think that's why you need another trial.
Can you join me in thanking Dr. Beca?